Hello everyone. Today, we're going to talk about a health condition that impacts over 1 billion people worldwide, hypertension, more commonly known as high blood pressure. It's often called the silent killer because it progresses without obvious symptoms, yet it's a leading cause of heart disease, stroke, kidney failure, and even premature death. Our goal today is to look beyond just the numbers on a blood pressure cuff and truly understand its profound impact, its various causes, the sophisticated ways we treat it, and crucially, the hidden risks of superficial management. It's about treating the whole person, not just the pressure. Let's start with the basics. Hypertension is simply high blood pressure. But its simplicity in definition belies its immense impact. We're talking about a condition that affects over 1 billion people across the globe. This isn't just a number, it's a critical public health challenge. High blood pressure stands as a leading risk factor for the most devastating cardiovascular events, heart attacks, strokes, and kidney failure. Its danger lies in its silent nature. It often causes damage for years without noticeable symptoms, making awareness and proactive management absolutely essential. The most critical consequence of uncontrolled hypertension is its relentless damage to the heart. Imagine your heart as a pump. With high blood pressure, it's constantly pumping against a much higher resistance in your arteries. Over time, this chronic strain leads to structural changes. The left ventricle, the heart's main pumping chamber, thickens, a condition called left ventricular hypertrophy, or LVH. While this might seem like a temporary fix, this thickened muscle eventually stiffens, losing its ability to relax properly between beats. This is an early, crucial step towards heart failure. In advanced stages, we see myocardial fibrosis, or microscopic scarring of the heart tissue, further compromising its function. This creates a dangerous cycle. Hypertension damages the heart, and that damaged heart, in turn, makes it harder to control blood pressure. Understanding this intricate relationship is key to effective treatment, moving beyond just lowering numbers. Effective hypertension treatment is complex and personalized. It's rarely a one-size-fits-all solution. While the primary goal is always to lower blood pressure, modern pharmacologic treatments do much more. They're designed to address the underlying structural and biochemical pathways involved in hypertensive heart disease, offering benefits that extend beyond mere pressure reduction. These medications often play a dual role, providing crucial cardiovascular protection, which is why many are also used in heart failure management. Let's explore some of the key classes. First, we have ACE inhibitors, like lisinopril and enalapril. These drugs work by blocking the conversion of a substance called angiotensin I into angiotensin II, which is a powerful constrictor of blood vessels. By reducing angiotensin II, ACE inhibitors lower blood pressure, help the body excrete sodium, and importantly, they also help limit or even reverse the structural changes in the heart and kidneys that happen with long-term hypertension. Angiotensin receptor blockers, or ARBs, like losartan, achieve very similar effects by directly blocking the angiotensin II receptor. They are a great alternative for patients who develop a persistent cough, a common side effect of ACE inhibitors, while still offering excellent protection for the heart and kidneys. Next, we have beta blockers, such as metoprolol. These medications reduce the heart's workload by slowing down its rate and dampening the body's adrenaline response. They are particularly vital in patients who have heart failure with reduced ejection fraction, have had a heart attack, or experience certain irregular heart rhythms. They offer powerful dual benefits for these patients. Calcium channel blockers, like amlodipine, work by relaxing the smooth muscles in our blood vessels, allowing them to widen and reducing resistance to blood flow. They are notably effective in older adults and in Black patients. Some types, like diltiazem, also help slow the heart rate and are used for rhythm control. These can be safely combined with other blood pressure medications. Finally, diuretics, often called water pills, are a cornerstone of hypertension treatment. They work by helping your kidneys excrete excess sodium and water, which reduces your overall blood volume and, consequently, your blood pressure. Thiazide-type diuretics, like hydrochlorothiazide, are particularly effective in individuals with salt-sensitive hypertension, which is common in older adults and African American populations. More potent loop diuretics are typically reserved for significant fluid overload. Beyond these established classes, the field is constantly evolving. We're seeing exciting developments with medications like SGLT2 inhibitors, originally for diabetes, now showing significant cardiovascular benefits, and promising device-based treatments like renal denervation for patients with very difficult-to-control hypertension. Let's shift focus to a crucial but often misunderstood aspect: sodium's impact on blood pressure. When we consume too much sodium, our body retains more water to dilute it. This expands our blood volume, increasing the pressure inside our arteries, much like adding more water to a closed plumbing system. Here's the paradox: your routine blood test for sodium usually looks normal, even if you eat a high-sodium diet. This is because your kidneys and hormones work hard to keep your blood sodium concentration stable. So, a normal blood sodium level doesn't mean diet isn't a factor in your hypertension. Instead, healthcare providers look at dietary habits, sometimes urine sodium levels, and how your blood pressure responds to a low-sodium diet to understand its role. When diagnosing hypertension, it's vital to determine its type. The vast majority of cases, 90 to 95%, are primary or essential hypertension. This develops gradually, influenced by a combination of genetic predisposition, age-related arterial stiffness, our lifestyle choices like high sodium intake, obesity, lack of activity, and chronic stress. There isn't one single identifiable medical cause, it's a multifactorial condition. However, the remaining, less common, form is secondary hypertension. This is critical to identify because it results from an identifiable underlying disorder that, if treated, can often cure or significantly improve the hypertension. Causes range from chronic kidney disease and narrowed kidney arteries to hormonal imbalances from adrenal or thyroid issues, obstructive sleep apnea, or even side effects from certain medications. Spotting these hidden causes offers a chance for a targeted and potentially curative treatment. Hypertension is rightly called the silent killer because it often wreaks havoc on vital organs before any symptoms appear. When a high blood pressure reading is seen, and a medication like a diuretic is prescribed, and the numbers come down, it naturally feels like a success. The patient feels better, the doctor sees improvement. But this seemingly positive outcome can hide a dangerous reality. If the hypertension is due to an underlying cause, a narrowed kidney artery, undiagnosed sleep apnea, a hormonal imbalance, simply lowering the blood pressure with medication doesn't fix the core problem. The root cause continues its damage, just silently. This means we might miss a chance to actually cure the condition and expose the patient to unnecessary medication risks without truly resolving their health challenge. Healthcare providers are trained to look for red flags like very high BP at a young age or difficult to control pressure, which prompt a deeper investigation beyond just managing the numbers. Modern hypertension guidelines emphasize a highly personalized treatment approach, moving away from a one-size-fits-all model. Initial medication choices are now tailored based on individual factors like age, racial background, coexisting medical conditions, and overall cardiovascular risk. For example, while ACE inhibitors, ARBs, calcium channel blockers, and thiazide diuretics are all considered first-line options, for Black adults without chronic kidney disease, thiazide diuretics or calcium channel blockers are often preferred due to better efficacy and outcomes in these populations. Conversely, for patients with diabetes or kidney disease, ACE inhibitors or ARBs are favored for their organ protective effects. The general target blood pressure for most patients, especially those at high cardiovascular risk, is less than 130/80 mmHg. However, just as important as lowering blood pressure is avoiding overtreatment. Pushing blood pressure too low can lead to dizziness, falls, and even reduce blood flow to vital organs like the brain, heart, and kidneys, especially in older or frail patients. It's a delicate balance. Let's delve deeper into diuretics. While incredibly valuable and often essential, especially for hypertension and heart failure, their use isn't universally indicated. Giving a diuretic to a patient whose high blood pressure isn't primarily caused by excess fluid can create new problems. We risk exacerbating dehydration, leading to dangerously low blood pressure, dizziness, and falls. It can also lead to acute kidney injury by reducing blood flow to the kidneys. Furthermore, diuretics can disrupt vital electrolyte balances, particularly lowering potassium, which can cause muscle weakness and dangerous heart rhythms. They can also worsen conditions like gout or make diabetes harder to control. Despite these risks, diuretics remain a cornerstone of hypertension treatment for most individuals with primary hypertension, where subtle fluid retention is often present. They are highly effective, cost-efficient, and have strong evidence for reducing serious cardiovascular events. The key, as always, is careful patient selection and continuous monitoring of blood pressure, kidney function, and electrolytes. While medications are undoubtedly crucial, we cannot overstate the importance of lifestyle modifications. These are the absolute cornerstone of both hypertension prevention and its long-term control. Simple yet powerful changes include reducing dietary sodium, ideally targeting less than 1,500 milligrams per day for high-risk groups, engaging in at least 150 minutes of moderate-intensity exercise weekly, and achieving even modest weight loss, which can significantly lower blood pressure. Limiting alcohol intake, quitting smoking, and effectively managing stress are also vital. Patients who truly commit to these lifestyle changes often find they can reduce, or even eliminate, their need for blood pressure medication over time. This empowers individuals to take an active role in their own health journey. In conclusion, hypertension is far more than just a numerical diagnosis. It's a critical window into a person's overall cardiovascular health and future risk. Effective management demands that we look beyond simply suppressing the numbers on a blood pressure cuff. We must strive to uncover underlying causes, diligently monitor organ function, and deploy treatment strategies that are deeply personalized to each individual's unique needs and circumstances. Whether through precise medication, dedicated lifestyle changes, or advanced diagnostics, the ultimate goal remains the same: to preserve heart and vascular health, prevent devastating complications, and ultimately, ensure a high quality of life. By focusing on the whole patient, rather than just the blood pressure reading alone, healthcare providers can offer care that is not only effective in the short term but truly enduring for lifelong well-being.